Good afternoon, everyone. Thank you for coming in today. We have a very distinguished speaker today. um, Dr. Wadei is one of our transplant nephrologists here, and he's also a research chair here. Dr. Wadei, what we're seeing is the split screen.
Okay.
You want to split? Yeah.
So we go presentation mode. I guess what do we do?
Yeah. Go to go down. Go to slideshow at the top there.
Okay. Yes. I will just share my screen first and then do the slideshow.
Yeah.
Still split screen, right?
Okay. And yeah, and then see where it says display settings at the top there. Click on that. The top middle.
Yes, display
Yeah.
settings, yes.
And I think you click the top one. There you go. You got it. Okay. So
Perfect.
we do ask that you guys not record this. We are recording it and we'll put it out on the YouTube playlist for you. So please don't record it. Please make sure that your microphones are off. All right. And take it away, Dr. Wadei. Thank you.
Well, good afternoon, everyone. I think we have quite a bit of participants, at least 29 here. Probably that would be keep on adding up as we speak. My name is Hani Wadei. I'm one of the kidney transplant physicians. I'm not a surgeon who has been here at Mayo for almost 20 years. And as Pat alluded to, I'm the Director of Research for the transplant department. So I oversee research on different organ sites, including heart, liver, lung transplant, as well as the kidney transplant part. Okay, so we'll update about important things, and we have like a bird eye view about how Mayo envision the transplant related research and how we can use this to advance the field. Then we will go over some specific projects. Some of them at Mayo, some of them at Mayo have not done much work in it yet, but how, and we'll see how this will help the transplant patient to get an organ in a timely fashion. So let's move on. So if you want to look, again, we're talking about the bird eye view here. The modern transplant timeline is very short. It's only around 70 years or so. So compared to the overall history of medicine, which I'm from Egypt and I went to one of the museums. I was trying to get you guys a picture, and there was medical instruments, surgical instruments in this museum that the pharaohs used to do operation and surgeries and all this. So this is like 5,000 years ago. And now we're talking about a limited time frame, only 70 years of transplantation. So the first successful kidney transplant was in 1954. First successful liver transplant was 1963. Okay, and that was done in a lab, but to a human was 1967. Heart transplant first time was 1967 as well. At that time, to expand the transplant field, we have to make a simple definition of death and then deceased donor. Then the Harvard criteria came in 1968 to determine what death exactly means and how to diagnose it. Then the Uniform Determination of Death Act was not till 1981. The most effective medication we use for preventing rejection after kidney transplant are a group of medication called calcineurin inhibitors. And again, these are utilized in kidney, heart, liver, lung, even bone marrow transplant. And the calcineurin inhibitor was first found in 1983. Only like 40, 50 years ago. And the first medicine of this group was called cyclosporin. First time got approved in 1983. Later on, 10 years later, the second member of this group was tacrolimus, was approved as well. In 1984, the UNOS, which is a Organ Procurement and Transplantation Network, was established. 1986, the solutions that we used to preserve the organs was standardized, and there is a gap of silence till around 2010, when the whole idea started about organ rehabilitation. Okay, how can we maximize the use of organs? How can we use organs that otherwise not suitable for or considered not suitable for transplant? How can we make it suitable? And we started here at Mayo an amazing experiment with the lung transplant, where they get the lung, which are not suitable for transplant, they put them in an incubator on a ventilator for 2-3 days. During these 2-3 days, they try to treat the lung and turn it around from being a non-suitable organ to a suitable organ. So I'm not going to go over this in full detail because the purpose here is kidney transplant, but we made an organ rehabilitation unit where lungs not suitable for transplant, say coming from Georgia or coming from North Carolina, comes to us, stay in an incubator in a ventilator, and during this time, the doctors try to medicate this lung, treat this lung, and turn it to become a suitable organ for transplant, and ship it back to a person in Georgia, for example, for a lung transplantation. So this idea was not till 2010 or 2014 when it started to happen. Also, another idea was to use machine perfusion. We always use static cold storage, or take the organ, whatever kidney, heart, lung, or liver, and flush it very well with a solution called saline, then flush it with a preservation solution, like chemically balanced solution, to make the organ not in chemical imbalance, and then cold store it on ice, put it in a cooler with ice, and make sure that this organ is on ice till it gets to the recipient. But things have changed. We can put this organ on a machine that provides circulation inside the organ with, initially, it started with the same preservation solution we use, and then they played around with different temperatures. So from sub-zero Celsius to around 0 Celsius to now almost normal body temperature, to find out how these different machines, and instead of using the organ preservation solution, sometimes they use blood to provide oxygenation to these organs. So the machine perfusion is the new kid on the block now, and the whole transplant community trying to find a place for this machine perfusion, because it's an expensive kind of procedure where you take the organ, say you can take the heart, cannulate it, and infuse circulation in the heart while you're transporting it from the donor to the recipient. And you can imagine that this will increase the travel time, because during this time, the organ is being taken care of with the circulation. Sometimes this is at either hypothermic, means a little bit cold than body temperature, or normothermic, at body temperature. Blood circulation provide oxygenation to the organ as if this organ never left a human body. And then you can transport this organ, and while it's being transported, it's being oxygenated and cleared from any waste products that is being produced, cleared from any inflammatory products because of the injuries from the surgeries and all these things. So it comes to the recipient ready to work right away. So with this machine perfusion in the last 8 to 10 years has seen a great increase in studies and increased interest by Mayo here and other transplant centers in using this machine perfusion in different organ transplants. In 2020, xenotransplantation became a reality. I was a fellow at Mayo Clinic in Rochester more than 20 years ago, and I heard the talk about xenotransplant from the guy who was one of the main scientists who worked on xenotransplant. And it was sounding to me like a very, very remote goal. It sounded to me like it's worse than, it's easier to go to the moon or to Mars than do this xenotransplant because of multiple barriers. But I'm sure all of you have heard about the successful xenotransplantations that happened recently, and we're going to go over it. Okay, so this is just a quick overview of the timeline. During this timeline, we had multiple successes. We know that we can recognize organ failure. We know how to do organ transplants. We have learned the hard way how to use marginal donors, means DCD kidneys or kidneys from somebody who whose brain is still working, but his heart is not. Kidneys from marginal donors, like old age donors with hypertension. We use organs from hepatitis C infected donors, and we use those in hepatitis C uninfected or hepatitis C naive recipients, and we provide treatment for the hepatitis C to avoid that the recipient will be hepatitis C infected. So by doing that, we increase the utilization of kidneys and limited the waiting time on the transplant list. We also know how to provide post-transplant care before and after, and even on the long term. We know how to prevent rejection. We have to diagnose and prevent infection, and if it happens, how to treat the infection. We have developed, or not us, the field has developed much newer and much more potent antibiotics and antiviral and antifungal to help us with the infection problem after kidney transplant, and how to better select the best organ for the best patient, how to match all this. And because of that, there was many successes. So, and these successes are related to organization successes, like Mayo Clinic spent a lot of money and resources and infrastructure to build transplant programs, right? Institutional success means each program has to build infrastructure in terms of nurses, coordinators, technician, people who can manage this procurement machine I'm telling you about, patient who can take calls at night to direct these organs to the recipients, call the recipients in the middle of the night, get them ready for a transplant. Medical successes and surgical successes, improvement in the surgical technique, improvement in the preservation solutions, medical successes mainly related to new medication, how to apply this new medication, what's the best patient for this particular medicine. So because of all these successes, we have seen that there is more than 1 million solid organ transplant has been performed in the US over like around 20-year period, or actually 40-year period. But there is still some things that we need to improve upon. Well, first, we know that we need to have an organ to do a transplant, and not these organs are in the best shape to be transplanted. We know that we need anti-rejection medication, which have side effects, and sometimes this puts you at risk of infections and cancers, and the transplant depends on it. Transplant surgery itself is an adventure that sometimes have a little bit of unknowns in it, and we have to do something about that. Maybe we should prevent the transplant from being needed from the first place to better help the patient rather than proceeding with a transplant. Timing of the transplant is unpredictable. Today, we have 3 kidney transplants being done at the same time. You can imagine that last night how my night was, staying on phone calls all night, trying to find the ideal recipient or talk to the recipient, look at the recipient chart, what we're going to do to this recipient when we get here. Accepting organs is totally unpredictable, happening overnight. And then on the other surgical side, they will be scrambling how we're going to handle 3 kidneys at the same time, who came to us from 3 different geographic locations. So they have to find 3 surgeons, 3 operating rooms, and 3 technicians to help, 3 residents or fellows to help. So all this is kind of create a big list of inconvenience to everyone. It would be nice to know if the transplant will happen at 8 o'clock in the morning and everybody would be prepared and would be planned to do it. We know that transplant costs a lot of money. We should focus on that and try to limit it. And in doing that, we should not look at the dollar amount, because dollar amount is one thing and a value-based amount is another thing. So basically, you can pay more money. Say you're going to hire a technician to run a machine perfusion for this particular organ, for this particular kidney. But this will make the kidney work right away to avoid dialysis. So there is cost of dialysis. You're going to pay the technician money. You're going to pay the machine, a company who does the machine money. You're going to pay maybe more money for transportation. So you'll end up at the end of the day having a lot of upfront cost or upfront dollar amount, but on the back end, you're saving money too by avoiding dialysis, avoiding prolonged hospitalization, by giving better kidney function, by avoiding any complications that happen from the kidney staying on ice for a long period of time. All these you're saving on the back end. So it has to be value-based, not dollar-based cost, okay? We also know that the organs, the kidney, no matter how it lasts, it's not gonna last forever. So yes, I see patients, I said I've been here 20 years, I see patients who we transplanted 20 years ago. Okay, our doors for the program opened in 2022. I came here, I'm sorry, in 2002. I came here 2005. So I see people we transplanted in 2005 till now. And they're doing good, kidney function is good, but I have seen many others who are back on dialysis and they're waiting for a second kidney and sometimes third kidney transplant. So we know that organs don't last forever. So we have lots of challenges as an organization here at Mayo or as a community, transplant community overall, to address. So how are we gonna change that? I think we have to stop thinking about how the future will look like and start thinking about we need to create this future, okay? So what are we doing to do that? We just looked at the problem, okay? There is imbalance between supply and demand, okay? So the supply is high. Many people are waiting on the transplant waiting list. For the kidney transplant, more than 120,000 are waiting on the transplant waiting list nationwide. Only around 20 to 22,000 will get transplanted every year. And more will be added to the list every year. So the list keeps on growing. And the reason why there is a problem of organ failure is higher than what we can transplant. So there is always an imbalance. So we have to work on preventing organ failure. And if you get a transplant, prolong this life of the transplant and preventing the rejection and doing the best immunosuppression management. And on the other end, we have to increase the supply. So we have to restore whatever organs we cannot transplant right away or need some refurbishing. And maybe build new organs from the scratch to meet the high demand we cannot keep up with. So the way we're looking at it, that these are the three Mayo sites, Mayo Rochester, Jacksonville, and Mayo Arizona. Okay, we did almost 29,000 kidney transplant, kidney, liver, heart, and lung since we opened our door in Rochester in 1963. Of these, 1,800 were performed in 1 year in 2021 alone. So that put us as the biggest transplant center in the whole world, okay? And we set the targets, we picked all from the list I told you about, the challenges that we need to do: tissue engineering, and this will be focused in Florida. Cellular therapies and intervention, this would be focused in Mayo Clinic Rochester. And immunological work or immunological advancement, this will be Mayo Clinic Arizona will be responsible to do that. And in doing that, we put 4 main goals for the transplant in general and for the kidney transplant in specific. How are we going to change the landscape for transplantation? So first, we have to restore organs. As I told you, here in Florida, we have a center, take lungs and restore them, put them on a ventilator and incubator for a couple of days till they become more suitable for transplant. And by doing that, we can decrease organ discard rate. I just told you too about the machine perfusion, which actually helps increase the type of transplant that people are afraid of, which is called DCD, donation after cardiac death. Basically, these donors had a sublethal brain injury, and the doctors cannot declare them brain dead, so they cannot take their organs. So what they do, they take them to the OR, discontinue circulatory support, and see what's going to do. If they pass and they survive, then they're not going to take their organs. If they pass away, then they can take the organ, but there will be around 1 to 2 hours of time frame where the organs are in the patient, but the patient has low blood pressure, suboptimal conditions that eventually will damage the kidney or cause injury to the kidney. Then you take this kidney and put it in somebody else, and it does not work. So by doing machine perfusion in the middle, rather than put it on ice, you actually help recover this kidneys. So that's as far as organ restoration plan we have. What about preventing graft failure in patients who already have received an organ transplant? And the goal is to have 1 kidney or 1 liver or 1 solid organ for each patient. Actually, one of the AI projects, so we had an application for AI projects, open ideas in the transplant center, in the 3 Mayo sites in general. And that we thought that we're going to get 20, 30 applicants. I think they ended up with more than 400 applicants. But the project that was kind of thought of to be started is an AI project mainly to monitor the immunosuppression drug level after kidney or any other organ transplant. And by doing that, it will alert the transplant center that the dose of medication needs to be adjusted. And again, by doing that, we prevent rejection and prevent graft loss. So 1 organ will last forever. What about preventing the organs from failing to start with? Like you have somebody with a heart failure and he's coming for a heart transplant. But how about fixing his heart failure and avoiding him to get a transplant from the first place? We have somebody with kidney failure who is not yet on dialysis. His GFR 18-20. His kidney disease is still not suitable. There is no suitable treatment for it. What about getting this kidney disease to be treated, or at least to prolong the life of this kidney, to try to avoid dialysis forever? So the long-term plan is actually to create a clinical trial center to treat organ dysfunction, to see maybe we can prolong what we have first and get more mileage out of this heart, out of this kidney or liver, before, rather than needing a transplant, we could actually maximize what we have. And the fourth goal is to re-engineer new organs. Yeah, you can do that, or you can even custom-made organs, so you don't have to use anti-rejection medication afterwards. And you can custom use this organ so you can perform the transplant at an optimal time, and you don't have to get Dr. Wadei to be awake all night because he's taking this organ offers. And of course, you can do that through doing xenotransplantation. The reason why I put this in blue and not in red is that as of today, Mayo has not been indulged in the xenotransplant project as a whole, but other transplant centers have done great work on this, and we're going to go over it. So we do have 4 goals: restore the organs, maybe use machine perfusion, limit the discard rates, prevent graft failure, prevent organ failure, and re-engineer new organs. And in doing that, we will recreate the future. So we'll decrease dependence on organs, we'll use more refurbished organs, we'll limit the use of anti-rejection medication, we'll have a motto or a goal to have for every patient to get an organ at an optimum time, and decrease the cost by eliminating waiting time, by creating a value-based model in terms of not the dollar amount we're looking at. We are looking at the real cost of avoiding dialysis, real cost of prolonged hospitalizations, real cost of infections, real cost of cancer. So eliminating the value-based cost, and with all that, prolong the life of the kidney, prolong the life of the patient himself. We cannot do this alone, so we have been collaborating with some other academic institutions, okay? In doing that, some industry partners, companies, machine perfusion companies, some organ regeneration companies, and even sometimes people in the general community, other nephrologists, other cardiologists, who refers us patient, and if we're going to enroll them in clinical trials or get them involved in some investigative kind of approach, we just need always the help of the local physicians to help us in achieving that. So with that, let's talk about, so this is all a bird's eye view about the overall view of the history of transplant, how is the country is going with the transplant, how is Mayo Clinic in general is looking at the 4 goals of Mayo Clinic, which is organ restoration, new organ formation, preventing graft failure, and preventing organ failure. How we gonna do, by doing that, help the imbalance between the supply and demand, okay? So let's talk about specific things that comes across every time I have a conversation with patients, and every time I see patients, they ask me about. One of them is very common, called xenotransplantation. Okay, so what is xenotransplant? It's basically sharing organs across species. I told you my story that when I was a fellow 20 years ago, there is a doctor called Dr. Platt who was working. Mayo at the time paid tons of money to make a special lab for Dr. Platt to bring baboons and bring pigs and other animals to do experiments in pig to baboon transplant and such things. And it sounded impossible because he listed the barriers, and uh, as to me, it sounded like impossible to achieve. But I will tell you how we achieved it and we were able to overcome these barriers. So the most important one is pig to human transplant, and the pigs are being chosen to become the candidate animal to share their organs with humans because pigs are readily available. You don't need baboons. Baboons are not that common. You don't see them that often. Okay. They're easy to breed, the pigs. And one important factor, they have their size of the pigs, or some of the pigs, they have this exact same size or close size to our organ. So in the case of a kidney transplant, the size is important, but it's not 100% critical. But in the case of a heart transplant, because the heart sits in a specific size, in a specific patient, the heart has to be a matching size between the donor and the recipient. Same thing with the liver, same thing with the lung. So with pigs, you have a comparable organ size to those of human. So it was chosen as a species of choice to start the xenotransplant process. But there was two difficulties. One was biological risk. Two was immunological risk. When I say biological risk, I mean risk of infections. And when I say immunological risk, I mean risk of rejection or losing this organ because of the human will reject it out. When I say biological, means that there will be infection carried from the pig to the human that we cannot treat. So the first one was a biological problem, and this was overcome maybe more than 10 years ago. And the way they did it is that they did a special breed of pigs. And the pigs have an inherent viruses or microbes in them that the pig itself does not get infected by. But if you take the organ, put it in a human, then the human would be infected. So they did a special breed which is free of these microbiomes and free of these viruses, and they breeded the special breed in a dedicated facility which is totally isolated to avoid these pigs from getting infected from anything in the community. Okay, and this has been achieved. So this number one roadblock was a biological barrier, risk of transmitting infection from the pig to the humans, infections that commonly does not affect the humans unless this experiment happens. So they made this pig free of these microbiomes, and they kept on breeding it. The second one was more difficult, is the immunological risk or risk of rejection, because the proteins on the pig kidney, for example, is totally different than the proteins from our kidneys. So when the immune system, our immune system sees this protein, it will immediately attack it and cause this kidney to die right away and reject. So they had to overcome that by doing genetically modified pigs. And they identified the top 10 genes that they need to change. So the top 10 genes were 4 of them have to be removed from the pig to start with. So they did 4 removal, and then they said there would be 6 additions from humans. So they added 6 of the human genes to the pig and removed 4 of the pig genes from the pig. So these 10 modifications created the ideal animal to be transplanted in a human. And how they did that, they did not do it overnight. It's actually did it in a special, like in a stepwise approach. So they do the modification in the lab, inject it in an embryo, and get the embryo to grow, take some stromal cells from this embryo and inject it in another embryo completely, and take now the newly modified new version of the pig, or what we want the new genetically modified pig to look like. They use a surrogate mother to harbor this oocyte or embryo in it and become the genetically modified pig. They keep on doing this till I told you removed 4 different genes from the pig and added 6 other human genes to prevent rejection. Definitely identifying which genes to be removed and which genes needs to be added took many, many years to find and many experiments to perfect. But at the end, they kept on repeating the cycle till they removed the 4 genes and added the other 6 genes. Then now we have the magic pig, genetically modified pig. And then they can breed this pig, and then you potentially have unlimited source of organs, not only kidneys, heart and liver and all this rest, and then you can use this for human transplantation. So the reality actually came to us back in 2022, and this was a chilling moment, at least to me, because I was so depressed from Dr. Platt's topic or talk 20 years ago. He gave a gloomy look that this is impossible to achieve. But I opened one day the American Journal of Transplant Journal here and found this becoming a reality. And I could not believe it, because they used pigs to be transplanted in a human. But the first experiment was not, unfortunately, done in a live patient. It was done in a patient who is brain dead. So they took the brain dead person, took both kidneys out from this brain dead after definitely obtaining the permission of the family, took both his original kidneys out just to make sure that any urine coming after the transplant would be coming from the pig kidneys. And then they put both kidneys from the pig, the magic pig, 10GE pig, it's called, in the deceased, in the brain dead person. And the transplant surgery took 4 hours. And then they kept this brain dead person for another 3 days. And during these 3 days, they gave immunosuppression, okay, and they assessed the function of the kidney, and they assessed if there is how the immune system reacted to this kidney, and they assessed urine output. They did biopsies from the kidneys. They eventually removed the kidneys out at the end of the 3 days, and with again the family authority allowed the patient to pass away. But they use this information gathered from this whole experiment tremendously to know highlights here that there is no hyperacute rejection, which is the worst type of rejection. And this is why they did the genetic modification to start with. Okay, there was the technique overall of doing the surgery was successful. No life-threatening complication happened. No antigen from the pig detected in the human blood. And they were ready now to perform this experiment in a living person. And definitely a year later, it came to us that in Harvard University in Boston, they took a pig kidney from this 10 gene edited pig to human kidney and put it in a real person. The real person picture is available online, but I did not want to include it in this presentation. But you can search it. So the bottom line is that they picked a person who was desperate for transplant. Patient who's highly sensitized. We're going to talk about sensitization in a second. So he has very low chance of getting a kidney transplant, has been waiting on the kidney transplant more than 7 years. But above all, he was running out of dialysis access. So he cannot do dialysis for him. He was getting more vessel calcification. He has no hope of getting a transplant, and now the door for dialysis is closing. So there is the only doors left is to die. So with the patient permission, they took him in Boston and they did the xenotransplant the same way they will do the kidney transplant. As you can see here, this is the first week of his kidney function. The creatinine came down almost to 1 milligram per deciliter, and his kidney function was great, okay? And the patient was discharged from the hospital and was able to perform activity of daily living without any problem. They documented that he did not have a rejection, but around 40, 50 days after the transplant, he showed up to the transplant clinic. And I talked to the doctor who did who was taking care of him in Harvard, and they said we saw him in the clinic. Patient did not feel well. We admitted him to the hospital, but within few hours, he developed tachycardia and irregularities in his heart rhythm, and eventually developed acute heart failure, and he died. So unfortunately, he did not survive for too long, but he proved to us and to the whole world that xenotransplantation is becoming a reality. And yes, he died from a heart transplant of heart complication, but he died with a normal functioning kidney at that time. So we're gonna hear more about xenotransplant from the community. What about the highly sensitized patients? Let me explain a little bit what do I mean by highly sensitized. So sensitization means that our circulation have lots of antibodies against other humans. So basically, every patient comes for kidney transplant or any other organ transplant, we check his anti-HLA antibody level, otherwise known as PRA. So if everybody above, this is a scale that goes from 0 to 100. 0 means you're not sensitized at all, and 100 means you're 100% sensitized. Once the higher the sensitization rate, the less chance of finding a kidney. So in reality, what 20% PRA means, or 20% sensitization means, that if I run 100 kidney offer, or I lay down 100 kidneys in front of you, the chance is you're gonna react, or your body gonna reject 20 of the 100. If you are 40% PRA, the chances are you're gonna react or reject 40% of the 100. So since we know that, you don't get an offer from this 40%. So that will make the waiting time goes longer. And that's why UNOS authorize extra points for the highly sensitized patient, okay? But it is a problem, especially when it comes to 100% sensitization, because this limits the organ availability quite a bit, okay? So you'll find people highly sensitized wait 5, 6, 7 years on the transplant list with limited offers, okay? So how do we get sensitized? We get sensitized through blood transfusions, through previous transplants, through pregnancies, okay? And what happens when you get exposed to other human tissue? The human tissue would be seen by us, by your body, as this is a foreign protein, okay? And because it's foreign, your immune system will react to it as it's reacting to any microbe or virus, and it will make antibodies. And since this protein is called HLA, it will be anti-HLA antibodies, okay? These antibodies are made by a cell called B cells, which is part of the immune system. And initially, the antibody level will be up, but with time, it will go down. And sometimes can go below the detection limit, but the cells that make the antibody will stay forever, okay? And will be stored in the bone marrow forever. A patient gets exposed to the second time to the same HLA will reactivate the cells stored in the bone marrow to make more antibodies, and the production will be much faster and at a much higher level than previous exposure. So that will cause bad rejection. So how to handle this antibody? There is a process called plasmapheresis. That's a machine like dialysis, but instead of removing sodium and potassium and things like that, it removes protein. And since the antibodies are protein, they will be removed with the plasmapheresis, but because of the cells, the factories that make the antibody is still present, this is not a highly effective measure, because what you're going to remove, you're going to replace again. You remove it, you replace it. So it's not really beneficial. Another way of doing this is to give immunoglobulins, or IVIG, intravenous immunoglobulins. This immunoglobulin actually has some benefit, okay? Because it binds to the anti-HLA antibodies and neutralize it, okay? So preventing it from being active, okay? And it does have also some activity against the factories that make the antibody, which is the B cell, by suppressing its antibody formation property. But it is still not highly effective because of the immune system and the way it's designed. And I will show you a picture here on how this immunoglobulin, this is how the immunoglobulin look like. It will bind in the circulation of the anti-HLA antibody, preventing them from causing harm, so neutralizing them, or it will bind to the cells that make the antibody in the bone marrow, preventing them from actually making more antibodies, okay? But the more promising thing is cell-targeted therapy. And these are medications that specifically kill the B cells or memory B cell or plasma cell, and these are the antibody producing cells. So we tried a medicine before, which is called rituximab. It's target a protein called anti-CD20, so protein called CD20, and the rituximab is anti-CD20, but it was not highly effective. Now we're targeting a different protein called CD38 with these two medications, and it is showing some effect. And it actually targets the plasma cells, the father of the B cell. So by targeting the plasma cell, you prevent the B cell, which later on prevent the antibody formation. So basically, you're taking care of the head of the dragon. This is the plasma cells. The tail, which we have been chasing all along, did not work. So now we are chasing the head of the dragon. And is there any report to support that? This report just came out a few months ago from Mayo Clinic in Rochester, where they looked at the efficacy of this anti-CD38 treatment in eliminating the antibodies in people with PRA above 80%, particularly in those above 99%. They showed at least that 40% of these patients responded. It's not 100. So with this medication, they were able to reduce the antibody in around 39%. The CPRA or PRA came down to the target levels. And during this study, 6 patients got offers, transplanted offers, which would not have gotten without receiving this medicine. And 4 eventually 4 out of 23 got transplanted. So 4 out of 23 is like almost 20% or so. So it's not high, but at least that's a signal that using this medication will open the door for the highly sensitized patients. Another thing that we've been doing here at Mayo in the kidney transplant field is using CAR T cells to open the door for this highly sensitized patient. CAR T cell has been developed over the last 15 years. This is chimeric antigen receptors. Basically, has been used to treat lymphomas and other kind of cancers, where the patient with cancer, we use his own cells to fight the cancer. So we harvest another immune cell called T cell. We harvest it and take it to the lab. And in the lab, we incorporate some of the tumor antigens, okay, and make a new cell called CAR T cell. We take these cells, chimeric, and this now cell can attack the cancer. We take this cell and put it back in the lab to replicate. And once it replicates at a high number, we give it back to the patient, and this cell will go and kill the cancer that the patient has. So basically, we use the patient immune cells, we modify it in the lab to attack the cancer, and use it to treat the cancer this way. So we said, why don't we use this same idea to attack the same cells that make the antibodies? And that's what we did. We took the blood from 10 patients who are highly sensitized with a PRA of 98% or more, okay? And we made specific CAR T cells. So we took the T cells from these patients, we made specific CAR T cells to attack the specific B cell in these patients that makes this particular antibody. And we infused it, we did not infuse it, we just did it in the lab. And in the lab, we're able to confirm that by doing that, we were able to target the B cell. So we took from the patient in the lab cells to produce the CAR T cells, and we take from the same patient the B cells. And after we proliferated the CAR T cells, we incubated them together, and we found that the CAR T cells killed the B cells. So that means that potentially, if we take this to the personal or to the patient level, it can work and eliminate the antibodies, opening the door for a transplant for these patients. Last highlight I want to share with you is a HOPE trial. And the HOPE trial is basically based on, in November 2013, the HIV Organ Policy Equity Act was signed, allowing HIV donors to donate to HIV recipients. And by that, we can avoid discarding the organs from the HIV donors, because we know we cannot take an organ from an HIV donor because it's going to transmit HIV to the recipient. But if the recipient already has HIV, then there is no harm in doing that. And we just starting this trial here at Mayo, and it will be run beginning of 2025. So let's summarize. Hope I did not take all your time. The transplant field in general, and in the kidney transplant field in specific, is new. It has evolved greatly over the last 6-7 decades, but especially in the last decades, it showed acceleration with the xenotransplant, with the machine perfusion, with the organ refurbishing. Okay, here in Mayo, we focus on organ rehabilitation, organ preservation, preventing organ failure, preventing transplant failure, and we will focus one day on regenerate some new organs. With that measures, we aim to close the gap between supply and demand, so everyone who needs a transplant can get one in a timely fashion, no phone calls in the middle of the night. Specific advancement, we talked about xenotransplantation in general, transplantation for the highly sensitized patients. We talked about the HOPE trial, and machine perfusion. I wish that we had more time to talk about it, but at least I alluded to multiple times during this presentation. With that, I would like to thank you for your time, and I hope that we covered good ground. I hope I will be happy to take any of your questions.
Yeah, I'm sure they have a few questions.
Okay.
Let's go ahead and unmute yourselves, folks, and ask their questions, or you can ask them in the chat. There's a question in the chat. How far off is xenotransplantation for everyday use?
It's becoming, it's not there yet, okay? But the barriers has been crossed. The two main barrier. Now, how are we gonna generalize this modified 10GE pig? Are you gonna find it in Publix next door? Not yet, okay? But this 10GE pig, which is a source of organs, once it becomes readily available, I envision that within the next decade, this would become a real reality. There is still some learning. Not everything is being revealed, but there is still other learning. I mean, from the two experiments I shared with you, the ones I did in the brain dead person and the ones I did in a living person, there was, I'm sure, tons of lessons learned and room for modifications. And this will help us a lot in the next decade to overcome all barriers left. And I envision that within 5 to 10 years, this would become a reality.
How will you have to use the meds after transplantation? I don't know what that means.
So,
maybe, yeah, okay.
so after transplantation, all the medication changes. Again, I will be specific to the kidney transplant. So whatever blood pressure medication, all these things, we start fresh, okay? So there will be between 2 and 3 immunosuppression medication, which are given orally. During the surgery itself and after the surgery, while in the hospital, we give IV medications. We start with something called induction that wipes out the immune system, followed by maintenance immunosuppression, and that is oral medications, okay? And because of the risk of infection, we give also between 2 and 3 antifungal slash viral and antibacterial. And this lasts for the first 6 months. The immunosuppression medication lasts forever, but it's oral medication.
I think the question really had to do with the pig transplant. So if you have a pig transplant, how's the, yeah, I didn't get
it. So for the pig transplant,
Mm.
they use the exact same medication what we use now. So they used induction medication at the time of surgery and followed by the exact same medication afterwards. So there was no major changes in immunosuppression medications.
Okay, the next question is there stem cell research going on to revive unusable cadaver kidneys to make them viable?
Yes, there is. We have a study to use stem cell transplant in kidneys with marginal kidneys, if we would like to call them. But unfortunately, none, the study did not recruit any of the, any organ, I would say. And therefore, we don't know the result of that. So the study was based on injecting the organ with stem cells and randomize stem cell versus no stem cell in large number of patients. Unfortunately, this did not happen because nobody kind of signed up for the study.
Okay, the next question is, my antigen score is, oops. My antigen score is in the low 20s. So if I understand right, that's good.
That's good. I mean, roughly means if we give you 100 kidney offers, you're gonna only 20 will be eliminated by chance alone.
Okay. Do you know of phase 2 or phase 3 studies on xenotransplant where patients can apply to enroll?
I don't know for sure, but this boat has been led by the University of Alabama, and they you can check off their website. Again, Harvard University in Boston, that's another one. The third one is Johns Hopkins in Maryland. So I am not sure if they have an ongoing study or not.
Okay. I actually have a question, Dr. Wadei.
Sure.
We get a lot of questions. The social workers are always asked about the artificial kidney, that little teacup thing that
Yes.
they're talking about implanting. What's the story with that?
Okay, so artificial kidney. As of yet, so the whole idea of artificial kidney is to create a machine where the blood will go through, will be filtered, and the clean blood, if you want to say it, circulate back to the patient. Unfortunately, this has not become a reality yet, to be honest with you. And part of it is the kidney is so smart and it's hard to replace by a machine. And the reason why the kidney is smart, so the kidney works in a way different than any other organ, and is that it depends on what you eat and what you drink for this particular day. Then the kidney will purify your blood, leave what you need and get rid of what you do not need, because it has so many sensors in it along the way, and so many checkpoints to make sure that the system is working perfect, to make sure at the end that what you don't need is eliminated and what you need is kept. This can be electrolytes, can be water, can be nutrients, can be just the BUN and creatinine, because you don't need them. So it's hard to replicate that. And to do it in a fashion that adjusts on a daily basis to what you ate is not easy. They were able to replicate the heart pump because the heart is a pump. It pumps blood, but the kidney works differently.
So the last message out here is that this patient had a kidney transplant over 3 years ago, and it wouldn't have been possible without Dr. Wadei and Dr. May advocating.
All
They're good
right.
advocates.
That's perfect. Thank you. Good to hear. I always take positive messages.
I know. Well, I'm going to give you another one. Thank you so much for doing this, Dr. Wadei. It's a really big topic. We actually had 111 people signed up for this today. I don't know where everybody went to. But very hot topic, and thank you so much for doing this. People love this. The patients love it.
I love it too.
Yeah. Well, thank you for doing it. We appreciate you.
Okay. Thank you so much. And please, I left my email here for a reason. If you have any questions, don't hesitate to email me.
Okay.
Okay. Got to hop to my next Zoom meeting. Thank you.
Okay. Thank you.
Bye.
Everybody take
Bye.
care. See you next month. Bye.
See you. Bye.